All right, we're at 7 o'clock, so we'll get started. Hello, and welcome to the Musella Foundation Brain Tumor webinar series. Our special guest today is Dr. Adam Sonabend, a neurosurgeon and researcher from Northwestern Medicine in Chicago. He'll be discussing his work with the SonoCloud 9 device and the Sonobird Phase 3 clinical trial for recurrent glioblastoma. We've got a good group online watching live. So for all of you, there will be a Q&A at the end. You can type your questions into the chat and we'll get to those later. Dr. Sonabend, thank you for your time tonight. Please take it away.
Thank you, Vanessa, and I want to thank also the foundation for hosting me. I'm a neurosurgeon and I'm also a brain tumor scientist, and I want to talk to you guys today about a novel way of delivering drugs into the brain. I'll start here with a disclosure of my conflicts. I have to state as a neurosurgeon, it's important to start with acknowledging that what we can do as part of the standard of care is somehow limited. And unfortunately, surgery is not providing a long-lasting benefit to the patients with malignant gliomas. And as you can see here, when a patient comes in with an MRI showing a brain tumor, you can clearly see the tumor. You can do excellent surgery, awake craniotomy, map the brain, do an extensive resection. Patient might feel great. The morale is very high. The post-operative scan does not show the tumor, but unfortunately, this is not the end of the story. And that's really basically because beyond where the gross tumor ends in the surrounding brain, there's always a few tumor cells that are lurking. And these brain tumor cells are hidden in the brain. And they are hidden in the brain, and therefore they're protected from the whatever is circulating in the blood by this structure called the blood-brain barrier. And I want to take a moment to briefly explain what that means and why this is so important. As you all know, the brain gets a lot of blood supply, and this blood supply goes through arteries and then goes to very small arteries called arterioles, and eventually makes it to these tiny little vessels that are microscopic, where barely one cell at a time can go through. These are called the capillaries. And the capillaries, I always think of them as a tight arrangement of endothelial cells that almost look like pancakes, and they hold each other very tight, and they don't let anything go through. As you can see right here on this cartoon, you have the tight junctions of the endothelial cells. And in there, you might have red blood cells, white blood cells, chemotherapy, whatever you might think. And on the other end of this structure, you have the brain. And in this brain is where you have these brain tumor cells hidden. When you inject chemotherapy, almost 95% of these drugs simply don't get across the blood-brain barrier. And sometimes, if occasionally something leaks through, there's actually pumps that will push it back into the circulation. So it's something really difficult, and it's very important for many species. It's conserved. It keeps our brain from getting intoxicated when we eat something we're not supposed to. But when it comes to treating infiltrative brain tumors and brain cancer, it's very inconvenient because most drugs really don't work and don't go across these. Temozolomide is the exception to the rule, but as you might know, it's unfortunately not a very potent drug. The problem with brain tumors and gliomas in particular is that there's almost no new drugs being developed for this disease, and we have to rely on drugs that are developed for other cancers that are more common. And these other drugs designed for other cancers were not designed to cross the blood-brain barrier, and therefore they're very limited for the most part. And so the technology I want to talk to you about today is the use of a combination of an ultrasound beam with tiny little microscopic bubbles. And you'll see here on the cartoon, the bubbles are in white. They're in the lumen of the tiny little blood vessels. And there's sound waves. And when these sound waves hit the bubbles, you suddenly get blood-brain barrier opening. This is a technology that was first, or a phenomenon that was first discovered by Dr. Kullervo-Hyönen. At the time he was at Harvard. He since then has moved to the University of Toronto. And for over a decade or so, this was clearly working in animals, but had not been tried in humans. In order for this to work in humans, these sound waves would need to either go through the bone or bypass the bone. And this is what I would consider the brilliance of Dr. Alexander Carpentier at La Sorbonne in Paris, who came up with this very elegant idea of implanting an ultrasound so you could bypass the skull. I'm going to go show you here a cartoon in a small video that explains how this works. So as you can see here in blue, you have the brain tumor, and as surgeon, I can remove the bone, remove the tumor, but there's this halo of brain where there's tiny little tumor cells surrounding it. And we use this device called the Sonocloud 9. It's developed by Carthera in France, and it's a grid of 9 ultrasound emitters loaded on titanium mesh. We screw that into a window in the bone. We cover this with a patient's skin, and then we inject bubbles into the veins of the patient. These microscopic bubbles that are already FDA approved but used off-label here go through the circulation and get into these capillaries. You can see them in white here. As you can see also the endothelial cells that line the capillaries are shown as well. And so to activate the ultrasound device, we put a needle through the skin and we connect it to electricity. And you suddenly can see here all the sound waves hitting the brain. The acoustic parameters are very similar to a diagnostic ultrasound, but when these sound waves hit the bubbles burst and cavitate, and you suddenly see openings and spaces between the endothelial cells, as you can see right there. And so we take advantage of this opening and inject chemotherapy into the veins. And as you will see here on this cartoon, this chemotherapy will suddenly, that is in the capillaries, will suddenly get access to permeate into the surrounding brain, depicted here as green little dots. And so that's how this works. I want to show you right now the results of a phase 1 clinical trial in which we describe the use of the Sonocloud 9. It's a study we published in 2023. In this case, we used a very potent drug called paclitaxel that is over 1,000-fold more potent than temozolomide, but that clearly does not cross the blood-brain barrier. So what we did here is combine Sonocloud, blood-brain barrier opening, with different doses of this drug. And so as you can see here in A, it's the ultrasound device, the Sonocloud 9 device. B shows you the needle that we use to connect the device to an energy source. The energy source is shown in C. There's this console that will activate the sound waves. And D is a CT scan of one of my patients. As you can see here, the staples that show the skin incision, how we close that, and how the ultrasound is basically mounted on this window in the bone. As part of surgery, we need to remove the bone to remove the tumor. And instead of putting this bone back, we go ahead and cover this defect, this window, with the ultrasound device. This is a very interesting picture, and I'll walk you through it. What you have above and below are two separate examples, two separate patients. And it's interesting to see the effect of the blood-brain barrier opening. On the left column, what you have here is the initial presentation MRI, where you have patients with recurrent glioblastomas. And the white area, if you can see my cursor here and here, will show the enhancing tumor. I always think of this as the tip of the iceberg, the part of the ice that is above water, the area that is grossly speaking tumor. And then the part of the iceberg that is underwater would be really the surrounding brain, where most of it is actually functional brain, but there are some lurking brain tumor cells hidden in there. And so this is the MRI that we have before surgery in these two patients. The MRI that we get after surgery is shown in the second column from left to right. And in this case, you'll see almost no enhancement because we've removed the tumor. And at this point, we've implanted the ultrasound device. Patient then goes home, and about 2 to 3 weeks later, comes back, gets another MRI as baseline, because sometimes there's some enhancement that develops in the first few weeks. This enhancement does not necessarily mean there's tumor growth, but sometimes it's the way the brain scars. And then what we go ahead and do is we connect the ultrasound to an energy source with the needle. We inject the microbubbles, and then we inject gadolinium, which usually doesn't go into the brain, because it does not go across the blood-brain barrier. And we also inject the chemotherapy. In this case was paclitaxel, but we've done this as well with carboplatin. And about an hour later, we get an MRI. And so what you will see here on the right column is all this white area around where the tumor used to be that is not seen on the second to last pictures. And so all this whiteness here is enhancement or gadolinium that permeated into the brain because the brain was made permeable. In other words, this white area shows blood-brain barrier opening where the chemotherapy is getting into the brain. You can see here it's covering very nicely the area where the tumor used to be. And the lower example, you see the same thing. And this is very important because it's been shown in about 80 to 90% of glioblastomas, the recurrence takes place in the first 1 to 2 centimeters around where the cavity is, where the tumor used to be. So if we can, if you will, marinate this part of the brain with chemotherapy at high concentrations, we might have a chance of achieving local disease control. Occasionally, when I was performing this clinical trial, I had cases in which I had to, as a surgeon, go through the non-tumoral brain or brain where there's only a few tumor cells in order to get to the tumor. And these were always cases in which this peritumoral brain was not eloquent. What that means is that patient wouldn't have any symptoms from incising this part of the brain. And that's because the brain has a lot of plasticity and there's several functions that are highly redundant. This picture shows one of those examples. To get to this tumor in the temporal lobe and the mesial aspect of the temporal lobe, we need to cut through the lateral aspect of the temporal lobe. So in cases like these, we did this study to try to understand what is the reaction of the human brain to this technology and to this blood-brain barrier opening. What are the actual concentrations of chemotherapy that we can achieve? So when we did this, the goals of surgery were to image and disrupt the blood-brain barrier. For this, we use fluorescent, just like gadolinium. It's something that doesn't go across the blood-brain barrier, but it's fluorescent, and you can see it with a microscope in the operating room. The second goal was to determine the effect of this ultrasound on the concentrations of these drugs in the human brain. The third goal is the standard of care clinical goal of surgery, which is to remove the tumor. And at the end of all of this, we would go ahead and implant the device for follow-up treatments. So here, I'll walk you through it. This is a case like I described where we have opened up the skull and put the ultrasound device there. We put the needle to activate it. We turn it on and we inject microscopic bubbles. Then we inject the chemotherapy and we inject fluorescein. And then about 45 minutes later, we make a few samples of the sonicated and non-sonicated brain where we can measure the chemotherapy. We then go ahead and remove the tumor and implant the ultrasound device. So I want to caution if there's somebody in the audience that might not want to see this, I'm going to show you a video of a glowing brain where you can get to see this. There's no blood, there's no cutting, but I just want you to experience what this looks like. So this is a patient who has a right frontal tumor. What you'll see right here, this is the right frontal lobe. I had just finished doing the sonication with the microbubbles in the operating room. And what I'm going to do now is inject the fluorescein. And so you'll see the fluorescein first goes into the arteries of the patient's brain. Then it goes into the capillaries. So the whole brain turns yellow. And then very soon you'll see it's going to be washed away. And suddenly it's going to be only mainly in the veins of the brain. And within a few minutes, it's going to be clear from the blood as well. And so as you can see here, as time goes by, it is becoming more evident that there are two wheels of yellow. If you can see my cursor here, one in the top and one in the bottom. These are areas where the blood-brain barrier was opened by the ultrasound. The other gyrus that is uninvolved right here is no longer yellow. And on the left, you'll see some yellow, and this is the part where the tumor becomes superficial. And because the tumor, by the tumor, I mean the area that enhances, has no blood-brain barrier, that part can be easily seen. And so when we do an analysis of these, and A here, by the way, I'm showing you this same case that I was describing, who has a right frontal tumor. You can see all this peritumoral brain. The green arrows represent the area where we activated the ultrasound device. The red represents the area where we did not. And the yellow represents where the tumor becomes superficial. And so in this case, we injected intravenous carboplatin to this patient as we did this. And we found carboplatin concentration to be about 9 times higher in the area of the brain that got sonicated versus the area that did not. In B, what I want to show you is when we did this with paclitaxel in several patients, what we found is a 3.7-fold increase in paclitaxel concentration in the sonicated brain. This is true for absolute paclitaxel concentration as well as for the brain to plasma ratio of paclitaxel. So we have a multiple fold increase of these. But we do not have an increase in blood. This is important because we ruled out the fact that there could be blood contamination causing the results that we see here. And that's what I show you here on the right. Interestingly, in the case of carboplatin, which is what I show you in C, the increase is more robust. We have about a 5.9-fold increase in absolute concentrations in the human brain, 5.8-fold increase in the brain plasma ratios, but no real increase in blood. It's interesting how there might be more penetration of carboplatin than of paclitaxel, and I think that relates to the fact that carboplatin molecule is smaller than paclitaxel. So there remains to be some kind of a size limitation, but regardless, there's a very nice penetration of these two drugs into the human brain with this technology. Something that was very surprising that I want to share with you guys is that once you do this, there's very nice permeation of chemotherapy and of gadolinium into the brain, as you can see here. The top represents the patient MRI before sonication. The middle one in pink shows the MRI that was obtained after injecting the gadolinium just 6 minutes after blood-brain barrier opening. You can see there's a lot of white, and you can see here how the beams have opened up this area of the brain, blood-brain barrier. But then if you go ahead and for a different cycle, we deliberately delayed the infusion of gadolinium for 69 minutes, you're losing most of the penetration of this dye into the brain. Here we have this graph in which we quantify this. And so on B, I want to show you something really interesting. This is a graph that shows you how much permeability there is on the y-axis versus the time. And what you'll notice is that in the first hour, the human brain is able to repair itself and restore the integrity of the blood-brain barrier. And this I found to be fascinating. But what does that mean for the delivery of drugs? Well, so one thing that is super interesting that we've been able to study this by using tiny little microdialysis catheters implanted in the brain is that if you can get a drug that doesn't cross across the blood-brain barrier, you can get this drug into the brain of the patient by permeating the brain, by opening the blood-brain barrier with this ultrasound device. The drug will stay in there, and you can actually trap the drug. It's almost as if you were to open the door, get the drug in, and then shut the door just behind. And what you can see right here in blue is the concentration of this drug. It is carboplatin. In yellow is the concentration of this drug in the plasma. And in red is the concentration of this drug in the brain that was not sonicated. And so it's very clear that at some point there's actually more drug in the brain than in the plasma because we've been able to trap it. When you measure over time, the area under the curve shows a very nice significant increase. And that's all because we timed right the opening of the blood-brain barrier when the drug was at its highest concentration in the plasma, but then the door got shut, the drug was already trapped in the brain, and then it was clear from the blood. Similar findings we get with fluorescein, as you can see right here. And in a different study that I did as part of a different protocol, we had an opportunity to treat some patients with doxorubicin, which is another chemotherapy, and with pembrolizumab, which is an immune checkpoint blockade antibody. And to our surprise, when we had to do surgery even 2 days after sonication, we still see a very nice increase in the concentration of these drugs in the brain. So you can trap drugs, and almost the less permeable the drug is to the blood-brain barrier, the longer it might stay in the brain, which is, I think, very interesting. There's some really interesting analysis presented by Dr. Carpentier on a clinical trial that we collaborated on using carboplatin, where you can see how patients who got the drug delivered in a very nice timing, right shortly before blood-brain barrier opening, had a much better local disease control than those where the drug was delivered significantly later. And the other interesting thing here that you can see, and by the way, what I mean by that, cohort D is those patients that had the drug very nicely timed based on blood-brain barrier opening. What you can see here on C is that the areas of the brain that got the blood-brain barrier opening were exposed to higher concentrations of drug, and they actually had this halo effect where they were protected from tumor growth in this study. Here's an example of one of my patients on this study. This patient had a large tumor resected, and then we started giving treatment. And at some point, it seemed like the enhancement was increasing. We're a little concerned that this might be failing, but we kept doing treatments, and eventually the enhancement went away, and this patient did phenomenally well and remains alive to date. So I want to spend a few minutes just to wrap up discussing the Sonobird clinical trial. This is a randomized, open-label, multicentric clinical trial. It's a phase 3 clinical trial that uses the SonoCloud 9 device combined with carboplatin and compares those outcomes to those achieved by the standard of care with either lomustine or temozolomide. This is for patients who have a planned resection for first recurrence of glioblastoma. You'll find below a link with the most up-to-date information about this clinical trial on clinicaltrials.gov. Important things if there's patients that might be interesting on this. So this is comparing these two arms, as I mentioned. It is only for first-time recurrence. So if there's a patient out there who's interested in exploring this, I would advise that you consider this early on before you try a different drug. You can always try other things, but the clinical trials have a very rigid structure and might be very difficult to access once there's been multiple lines of therapy. Because this ultrasound device has a specific size, there's some geometrical limitations to the size of the tumor. The tumor needs to be about 5 centimeters in graded diameter or less. And this is very important also to consider for the oncologists and the neurosurgeons and the patients, as sometimes there's an MRI that suggests there might be tumor recurrent. And if this is not considered early on and additional confirmatory scans get done, at some point it might be fine, but there's always a risk that the confirmatory scan might already show the tumor to be larger than what's acceptable for these. This clinical trial will have over 40 sites in Europe and the US. We have already several of these sites open. We're going to randomize approximately 560 patients. The primary objective of the study is to compare the survival between the two arms. The endpoint here is going to be overall survival. Secondary objectives include progression-free survival, landmark overall survival analysis, response rate, tumor growth rate, adverse events, and quality of life. Here's the design of this trial. The patients get consented, enrolled, and then randomized. Then they undergo surgery. If they are in the control arm, the surgery is followed by treatment with these alkylating agents. If the patient is randomized to the treatment arm, then they get the implant of the ultrasound device, and then they can start getting treatment with carboplatin and blood-brain barrier opening. Some of the inclusion criteria, this is unfortunately only for patients with IDH1 wild-type tumors or glioblastomas who have failed already a previous line of radiation and temozolomide. They need to have measurable tumor documented within 14 days of inclusion, and there has to be at least 12 weeks from the conclusion of radiation, unless there's a new lesion. We discussed the size limitation. The patient should be eligible for a craniotomy for resection of at least 50% of the tumor and has to have a good performance status. It is only done for patients who are adults, and patient needs to be able to understand and be able to sign the informed consent. The Non-eligibility criteria, important things to consider. These are uh, excluding patients with multifocal enhancing tumor, unless all of these foci can be covered within this 5 centimeter area. This is important because we don't want to offer this trial to a patient we do not think is likely to benefit. Poor performance status, tumors in the posterior fossa or known to have BRAF or NK mutations, patients who are getting more than 6 milligrams a day of dexamethasone for over 7 days prior to inclusion, a patient who need to be an anticoagulation, or patients who have an other active cancer recently. This is a slide showing the European sites that have been activated, and I'm putting this out there in case there's a patient who's interested in exploring this trial. I would encourage you to look for a hospital or a center that is near you. So there's all these European sites that have already opened these. And similarly, we have all these clinical trial sites in the US where the trial can be offered. This is probably the most important slide where I acknowledge what I'm presenting to you today is work done by several of my colleagues, and I'm just here to summarize that. But this is some of the work done by my lab. Of course, the support by Carthera is very important, and I want to acknowledge that. I'm going to stop sharing here and maybe let any questions and happy to answer.
Yeah, we have a lot of great questions that have been coming in. So I'll just start with the ones here in the Q&A. First, do the microbubbles damage the capillaries when they burst?
Yeah, good question. I think the best answer is yes, they do. They damage the capillaries to the point where there's tiny little spaces between them. Now, to be accurate, it's very important to understand we haven't had an actual noticeable toxicity from these. What's remarkable about this is that the brain and those capillaries can repair themselves. And this is really important. There's never been any kind of brain tumor treatment that doesn't have any kind of secondary effects to the brain. But I will tell you, this has been surprisingly very well tolerated. Now, it might be different if we were to open the blood-brain barrier every day. This is not something that we are planning on using for drugs that need to be administered every day. But once every few weeks, we haven't seen any significant clinical damage.
Okay, and I had that thought too on, repeated sonications, whether you have to worry about maybe some long-term damage to the endothelial cells, to the capillaries. And on that note, what's the highest number of sonications that any GBM patient has had so far?
So we had a patient that had about 17 cycles in one of my
Okay.
clinical trials, and I thought that was remarkable. And again, uh, there was no significant clinical damage or MRI sequela that you could see. I am sure if you were to look under a microscope, you might find some scarring or something, but the patient tolerated it very well. It's unfortunate, but with this disease, the most damage is caused by a growing tumor. And
Exactly.
radiation, chemotherapy, surgery, they all in some ways can have some damage to the brain, but I will tell you, clinically speaking, this is very safe.
Okay. The next question is, can you use this device similarly to sonodynamic therapy with the 5-ALA?
That's an excellent question. I don't know the answer to this question, but I think it's worth exploring.
Okay. Um, would having this device implanted preclude you from using Optune? And has
No,
it been done?
yes, great. Thank you for asking. It wouldn't. We actually have a different clinical trial that I did not talk about today, which is done in newly diagnosed glioblastomas, in which we are combining this with Optune. Uh, I did not talk about Optune today on the Sonobird trial because, as you know, Optune has been shown to prolong survival when used at time of diagnosis, but unfortunately in the recurrent setting has not been shown to be beneficial. So we don't usually recommend it, but there's nothing wrong with it, and it's been well tolerated. These two can go along.
And in that newly diagnosed trial, the chemotherapy that's being used is the Abraxane, is that
Oh,
correct?
yeah, no, this is a different trial. It's a
Okay.
small early phase trial, but what we're doing is not for chemotherapy, but for immunotherapy that we're using this.
Okay. Okay. And can you talk a little bit more about kind of future directions for other combinations, with
Yeah.
immunotherapies? Obviously, if you've got one trial going, maybe you have more planned, or other chemotherapies maybe down the line that might prove successful.
Yes, of course. Thank you for asking. This is an excellent question. So the first thing I will tell you is this device and this technology works. It's safe, it's feasible, you can use it repeatedly, you won't hurt anybody. What it does is it gets drugs into the brain. Whether somebody lives longer depends on the drug. I always think of it a little bit like, well, is a intravenous injection efficacious for glioblastoma? Of course it is, right? Like if you have a very powerful drug and doesn't make it into the blood, it won't work. But injecting something intravenous does not necessarily mean there's going to be efficacious. So I'm very hopeful about the current study we're doing with carboplatin, but I think this is not a treatment. This is an approach to get drugs into the brain, and the sky is the limit. This might be very effective for other lines of therapy, particularly things that are injected into the veins, things that don't require a daily administration for obvious reasons, might be very effective. And so, just to share some preliminary studies we're conducting, we're currently, as I mentioned, doing one with a very novel combination of immunotherapy in patients with newly diagnosed glioblastomas. That's a very small study, but if it looks promising, we might advance this further. There's other chemotherapy combinations that we're exploring, but this, I would say, is the first big efficacy assessment of the approach.
Okay, and actually, there's another question that ties in really nicely with that, and it's are there benefits of using SonoCloud versus direct convection enhanced delivery using a cannula directly to the tumor?
Yeah, so I have some experience with convection enhanced delivery. I think it's an interesting technology. There's a lot of geometrical limitations to it. For instance, if the tumor has a cyst, if it has an area that is necrotic, if it's near the sulcus or near the ventricle, when you start infusing this positive pressure fluid into the brain, it will work as a sink and then it will leak through that and you won't get a lot. That's one limitation. The other limitation is that it's hard to do it repetitively. And it's not something you do as an outpatient so easily. Um, and you need a new formulation of any drug you're going to use through convection enhanced delivery. So you need to determine the toxicity and package it. The advantages of this ultrasound is that once it's implanted, the procedure takes about 4 minutes to be performed. The patient's fully awake. This is done now by an amazing group of nurses, at least at my institution. And we use off-the-shelf drugs that are already very clearly shown to be safe for systemic delivery at doses that are already very well established with adverse events and toxicity that is already very, very well studied. And so it allows you to very quickly advance, trying new drugs in patients in a safe way.
Okay, I was actually curious too about the volume of treated area. You mentioned there's restrictions on what parts of the brain you're treating. For Optune, they do array mapping and they have, an AI platform that helps map, where they're going to target the electrical field. Is there similar mapping that goes on with where you place the SonoCloud device in relation to the tumor?
Yes, that's exactly right. So, first of all, as you know, I think this is the largest ever uh, ultrasound device, definitely implantable. But the field of sonication, I would say, is significantly larger than anything that we've seen before. But it might not be large enough for all tumors. And so it's a great milestone. We have to address that. We have to limit right now inclusion of patients who have smaller tumors or that will have a lobectomy where a whole lobe of the brain might need to be removed. When we are going to consider somebody for inclusion, we do study the MRI in 3D and model where this might be best placed. But then when I take the patients to the operating room or the surgeons do this, we use stereotactic navigation to optimize the orientation and the placement of the device, considering what part of the tumor is already being removed. Because what we need to target is not the tumor, but the brain that is left behind.
Okay. Okay.
One more thing I want to add is something really interesting. So as a surgeon, I'm limited with my resections to not dealing with eloquent areas of the brain that need to be preserved. And so if there's tumor in those areas, I need to leave this tumor alone. This device is very refreshing because you could target those areas with impunity. And so it's a very nice complement where you can deliver drugs to the areas that you simply cannot remove.
That leads perfectly into my next question, which is, for Sonobird, you have to, in order to be eligible, you have to be a candidate for a 50% debulking of the tumor. But theoretically, inoperable tumor, this device would still work for. So would that be tested in other trials, or do
Yeah,
you
that's a
think
good
that could be
question.
done?
So to clarify, all the work I've shown you today is on how this delivers drugs into the brain, not to the tumor. Um, to the brain, because the brain is the part that is actually protecting those few tumor cells that are hidden and that are the source of the recurrence. The tumor per se might not actually have a blood-brain barrier. The tumor develops its own blood vessels. This is why it looks white on an MRI because the gadolinium can permeate. So I'm not so sure. It's just we don't know enough about whether this really helps to deliver drugs to the actual tumor. But in general, as surgeons, we have no trouble removing the actual tumor in most cases. And what we're left with is a brain that looks pretty healthy, but that we know is unfortunately infiltrated by disease. So this is where this technology excels.
Okay. And just one follow-up question on that. When you report out results for Sonobird, for example, and you're stratifying outcomes, will that be something you look at, if the treatment field is closer to versus further away from the device?
Yes, of course. And there's a lot of exploratory analysis that will be done related to that. But it's, as you might imagine, across 40 centers and two continents, very difficult to completely control for that. So we'll explore all of that. But the primary design and outcomes of the study should be robust enough that are independent of these.
Okay. And okay, moving on. Have you used any advanced imaging like tumor burden mapping to differentiate between immediate post-treatment pseudoprogression versus true tumor growth?
Yes. You mean during the treatment with the sonoclot? Yeah, we've done a lot of this. We tried actually the patient I showed you. We did PET scan, and we did
Okay.
see that it was actually tumor, not pseudoprogression. And I was very happy to see. As you know, all the imaging modalities and advanced imaging modalities are not perfect, but this one was an avid lesion on PET that eventually just went away. So I was very impressed by that. We've used MR spectroscopy and MR perfusion. The problem is none of this is 100% reliable, and we have all seen cases where there's pseudoprogression that still it was equivocal, or cases where there's true progression and the results were mixed. But we routinely do it. It's just very hard to use this for decision making in the clinic.
Okay. Is the device left in forever?
Yes, for the most part, yes, it's surprising, but very clear. This really doesn't bother patients for the most part. Um, Occasionally, I removed one of these if I have to do surgery again afterwards. But unless there's a problem, there's really no justification, and patient would not be interested in having a surgery just to get this out, if that makes sense.
Okay, yeah, and I wonder too about like the long-term integrity because even patients that have the bone flap put back in, over time can have issues down the line. So, do you happen to know what the longest anyone, has had one of these implantables in?
So I have a patient that had this as part of a recurrent trial that has this now for over 3 years.
Wow. Okay.
I don't quote me to say that this is the longest anybody ever had it, but this is one example that comes to mind.
And these are being used in Alzheimer's patients as well. Is it the SonoCloud 9 that is
No,
being
it's
used, or it's
not
a
the Sonic
smaller?
Cloud. It's a smaller
Okay.
version.
Okay. Okay. Um, let's see. Oh, can you talk a little bit about the how the device translates in terms of survival outcomes? You know, those patients that were treated at kind of the optimal parameters, did they have a better prognosis?
Yes, thank you for asking. I have to be very conservative here. I think if you ask my anecdotal experience, I had several patients that I am convinced I have helped that did much better than expected. Many of them remain alive, and I'm really excited for them. I also, unfortunately, also had some heartfelt disappointments where I know that there's some patients where we tried this and simply did not work. I think that this has to do less with the technology and more to do with the biology. Some tumors are just very resistant to a given chemo, and some tumors are susceptible. The overall claims that these prolonged survival are the main thing we're trying to evaluate with the Sonobird. So I cannot tell you right now that this has made most people live longer. I'm not saying it has not, but I have to tell you, I want to be very, very conservative, and I'm doing this to get an answer to this question, not to prove anything.
Yeah, no, I really appreciate that answer. And just theoretically, if somebody was on the Sonobird trial with the carboplatin and they progressed while on trial and had to come off trial, could they theoretically try a different chemo in combination with the sonication?
Yeah, so it's a good question. I've done that in other studies. I don't know that you can do this without another clinical trial protocol.
Okay.
So it's very hard for me to say that would happen in this instance. Uh, I don't know.
Okay. For the current trials, is there any chance of expanded access for patients who do not qualify?
Yeah, I have to tell you, this is a very, very, very difficult path for the institution and for the companies and for the treating physicians. I have done a lot of these, but it's getting increasingly more difficult, and also regulatory wise, there's definitely a limit. So I would say the best one can do is hope that there's actual clinical trials that are open and formally set to test this technology in different ways. I'm working hard to develop additional studies and to expand some of the ongoing clinical trials. But the expanded access route might be one off situation, but it's not something that I consider to be a robust solution to most patients.
Okay. We had two questions on when will we see, either preliminary results for Sonobird or maybe results from some of the other Sono Cloud 9 trials? Is there anything we can look forward to soon?
Yeah, I look forward to this. I will say I have a clinical trial that I've just finished accruing. We're in the final stages of accruing, and so I would say for this ongoing trial, we should know another year and a half or so what the results are. Uh, as you know, what we need to do when we stop accruing is cross our fingers and hold the patient's hand and hope that they do very well for very long. As far as the Sonobird, I think it's going to take some time. We're actively accruing patients, but obviously we can't just tell yet.
Do you have a rough idea of where you're at in accrual?
I don't have these numbers right now to be
Okay,
quoted.
that's okay. That's okay.
Yeah, I'm
Um,
sorry because I'm on call. I need to just make sure. Uh, yeah, never mind.
it's okay. We're almost through, I think, all the questions. I'll just wrap it up with one last one because I believe this is from a patient.
Sure.
Um,
It's not an emergency, and I don't want to rush this. I just needed to check.
Okay. Are there any trials currently recruiting that would allow a patient at a second recurrence to enroll? Do you happen to know that off the top of your head?
With the Sonobird, with the SonoCloud device,
Yes.
No, I can't think of one.
Okay. Okay.
There might
Uh,
be, but not that I am conducting or that I'm aware of.
okay. Um, I think that's all. I'm trying to scroll through all the questions. Um,
As I mentioned, there's a trial that we have for patients who are concluding radiation, who have MGMT promoter unmethylated, and it's an immunotherapy trial where we implant the ultrasound device to deliver immunotherapy.
okay.
So that's a trial that, we are only doing at Northwestern, but there might be somebody who's interested in exploring that.
Okay. And Avastin would preclude you from entering any of the SonoCloud trials, right?
Not necessarily,
Okay.
not considered an anti-tumoral treatment, but there's a washout period for that.
Okay. Okay. And I think this is the last one, but I think you already answered it. They said Dr. Michael Levin at Tufts referenced a study using repurposed voltage-gated sodium channel drugs on GBM, but most drugs don't cross blood-brain barrier. Will other drugs eventually be tested other than chemo drugs? I guess I'll follow that up with um, how is the broader neuro-oncology community collaborating on what other drugs or treatments can be combined with focused ultrasound? And I know the Focused Ultrasound Foundation facilitates some of that, but how do you see that collaboration going?
Yeah, so maybe start with the answer to the question of what other drugs have been explored. So I have published data on carboplatin, paclitaxel, and paclitaxel is an interesting because it's not paclitaxel, it's a albumin-bound paclitaxel, so it's a very large molecule. Doxorubicin, which is a liposomal formulation, fluorescein, as you see, is a dye, and monoclonal antibodies. And so these are at least several drugs that they all get into the human brain without toxicity at significant increased concentrations. There's preclinical studies with many more drugs. We're exploring these also with the use of cellular therapies or CAR T cells. There's several groups looking at these. There's a lot of very interesting things that can be done, particularly for drugs that are injected systemically, intravenously, and drugs that don't need to be delivered every day. As far as the neuro-oncology community and collaboration, I mean, I would state that it's overall, as you know, a small and collaborative community that is passionate about helping each other. I had referrals from several colleagues across the country for this trial and for other related trials. I also look forward to discussing with different companies the possibility of exploring some of these, but there's unfortunately at some point a limitation of resources and funding to conduct some of these studies, right?
Of course, yeah. Um, well, that's all of our questions. So I'd just like to close by thanking you for your time tonight. Thank you for the wonderful presentation and so patiently answering all of these questions. We're really excited about this work and excited to see results, forthcoming.
Thank you. And if there's anything I can answer for anybody out there or any questions, please uh, uh, feel free to reach out. And thank you for the foundation for the support and forum.
Thanks so much. Good night, everyone.
Thank you.